Hello, everyone. My name is Benson Tanjong, and alongside with Muriel and Are, we are welcoming you to this third recording of our project of today, which will be focused on labor and introduction to epidural approach. So, labor begins at the end of 40 weeks gestation. That is the normal expectation. That at the end of 40 weeks, sometimes it comes at 38 weeks. Otherwise, anything below that will be considered like premature labor. But however, from 38 weeks to 40 weeks, we are expecting an onset of labor. And before then, 2 to 8 weeks prior to this period, we have what is called lightening. And lightening is like you start having some false type of contractions. And at the same time, there is descent of the fetus from the abdominal into the pelvis cavity where it engages and the fetus is getting ready. But we start having those false contractions. We call them Braxton Hicks contraction. And then 1 week prior to that, some ladies start showing with some bloody shore. We call it shore. You start presenting with it before finally you actually go into the real labor, which begins with contraction that becomes serious, they become intense, and they are not ceasing. And labor is divided into 4 different stages. But before then, the first stage of labor begins from those strong contraction that are intense to the full dilatation of the cervix. The second stage begins from full dilatation of cervix to the delivery of the baby. And the third stage begins from the delivery of the baby to delivery of the placenta. And after that, we have the postpartum phase, which comes with blood control, control of hemorrhage, and all of that. So those are the different stages of labor that comes into play when somebody actually sets, when a lady goes into full labor blue. And therefore, in the next slide, we'll be looking at how certain types of parameters changes when a woman goes into labor. And on this slide, we are seeing that generally during contraction, we have an increase, intense contraction increase your minute ventilation up to about 300%. Just to recall here that our minute ventilation is our tidal volume times our respiratory rate. So because of increased metabolic rate, increased consumption of energy, the woman tends to breathe at a very high respiratory rate. He's consuming a lot of oxygen, and that's why your minute ventilation increases like up to about 300%. Because of too much ventilation as well, you might go into a situation of hypocapnia where you're blowing off a lot of your CO2. And that is why a lot of women at this stage can easily go into a situation of respiratory alkalosis. Again, the contraction becomes intense, and as the contractions are intense and as the contractions are intensifying, there's increased flow of blood of about 300 to 500 mils of blood from the uterus to the central circulation, which means that during each contraction phase, it kind of decreases the amount of blood flow to the fetus because the blood vessels are contracting, and as a consequence, if contraction becomes too prolonged, there is a high possibility that a child can easily start developing a little bit of asphyxia or a little bit of hypoxia. That's why contractions are supposed to be short, but not too prolonged for a particular length of time because it compromises normal fetal physiology. Again, your cardiac output increases by about 45% during labor, which generally is a type of a physiological compensation for the vasoconstriction that comes into play when the woman starts contracting, because if cardiac output does not increase, it therefore means that each time a woman goes into that contraction phase, it's going to shunt off a lot of blood supply from the fetus. So what is going to happen that when you have an increase in cardiac output from the normal from their normal cardiac output that a woman was having during labor, during the pregnancy. The cardiac output increases in order to compensate for the vasoconstriction that comes into play during intense contractions of labor. This slide is just a summary of what I earlier said. Dilatation of the cervix marks the end of first stage, from dilatation of the cervix to the delivery of the fetus. Delivery of the fetus to deliver the placenta, and the fourth and the last stage is blood control, uterine contraction, and prevention of postpartum hemorrhage. So that first stage of labor actually is divided into two phases. We call the latent phase and the active phase of labor. And that latent phase, during latent phase, there is an increase in cardiac output by about 15%. And then during the active phase, the cardiac output increase up to about 30%. Latent phase generally is like between, I think it's about 3 to 4 centimeters dilatation of the cervix. But at this stage, labor is not yet so intense. The contraction are not yet that intense. They comes and they wanes very fast. But during the active phase, when you have those strong contractions that are not ending and the cervix is fully dilated, then the cardiac output as well increased by about 30% in order to make up for that contraction. And during the second stage of labor, where we actually have the delivery of the fetus, we have about 45% increase in cardiac output. Of course, there is increased amount of, there's increased metabolic rate, increased oxygen consumption. And to be able to make up with all of those demands, the cardiac output has to increase. Postpartum, after the delivery of the fetus, is showing that the cardiac output again increased by 80%. And the increase in cardiac output by 80% here is because at this point, everything is back to almost returning back. That vasoconstriction that we were seeing with all the contraction is not more there. So there is increased amount of blood flow to the uterus without any restriction. And the cardiac output as at that point is about 80%. And this diagram is kind of showing us the uteroplacenta circulation, how blood flows from the mom, from the uterus to the fetus during the whole gestation period. And this is very critical for the development of and maintenance of the fetal well-being. If we look at it carefully here, we can see that there are one umbilical vein and 2 arteries that are carrying blood supply to the fetus during this period. So the essence of this is just kind of show us that during gestation, there is supposed to be a constant flow of blood without any distortion from the mom through those 2 arteries and veins to the fetus and carrying of the oxygenated and waste material from the fetus back to the mom so that they get eliminated. Otherwise, there's going to be fetal retardation. And sometimes when, if the fetus is not doing well, especially if there is decreased blood supply, the child might go into a situation of in utero hypoxia, asphyxia, and might finally die from all the complications.
Hi, my name is Maria. I'm going to be taking over this session. I'm going to be talking about labor and physiological changes that occur with the uterine blood flow. So the uterine blood flow is your uterine arterial pressure minus your uterine venous pressure over your uterine vascular resistance. So there are various factors that decrease your uterine blood flow. You can have decreased perfusion pressure, especially when you have a decrease in your uterine artery pressure. Some of the factors that decreases your uterine artery pressure is the supine position. That's why it's always encouraged to do the lateral displacement. You also have hemorrhage and hypovolemia. You also have hypotension due to drugs, or when you do a epidural or a spinal, which causes a sympathetic blockade. You can have an increase in uterine venous pressure when you have venous cava pressure, and you have uterine contractions. Like I said, hypertonus drug induction, and also skeletal muscle hypertonus. You can have an increase in uterine vascular resistance. You have some exogenous and endogenous vasoconstrictors that cause an increase in UVR. Some of the endogenous vasorestrictors are catecholamines, which causes stress, and vasopressin during hypovolemia. Our exogenous vasoconstrictors are epinephrine, and you have vasopressors. It seems neosynephrine or phenylephrine has a more greater effect in comparison to ephedrine. Local anesthetics, especially in high concentrations. We will continue talking about the uterine blood flow. At 10, the cardiac output to the uterus is increased by 10%. That is roughly 600 to 700 mL per minute. The non-pregnant uterus, as we can see in comparison, receives only 50 mL per minute. So I guess 80% goes to the placenta, 20% goes to the myometrium. So there is a lack of auto-regulation, and the blood flow is maintained due to response to alpha-adrenergic agonists. Extreme hypocapnia results in decreased blood flow, and you have fetal hypoxemia and acidosis. That is why it's always essential for us to maintain the patient's blood pressure, because if the patient does not have a good cardiac output or a good blood pressure, the fetus will not get oxygenated, and that will cause fetal hypoxemia and acidosis. So this is also another review of the placenta physiology. The function of the placenta is for respiratory gas exchange, nutrition, and waste elimination. So the fetal and maternal tissue interface has an area of about 1.8 millimeters square. And if you look on this image, we just see it shows us like maternal veins, and we see like the arteries that perfuse the endometrium, and then we see this umbilical cord, we see the umbilical arteries, and the 2 umbilical veins as well. We will talk about placenta exchange, and for placenta exchange occurs with 5 mechanisms. We have diffusion, blood flow, active transport, pinocytosis, and breaks. So diffusion, when we have an area moving from an area of low, high concentration to an area of low concentration. So for example, we have respiratory gases and small ions and anesthetic gases can transfer into the placenta because they're small molecules. Blood flow, we can see that with water. Active transport requires ATP, and you will have amino acids, vitamins, and ions like calcium, and that we use active transport. Pinocytosis is we will use large molecules. We use this mechanism for transport, and some of the large molecules are immunoglobulins. And then for breaks, that occurs when you have like a break in the maternal and fetal blood, and then when they mix, that's where you have the RH sensitization. So we will talk about lastly on my part about factors affecting O2 transfer. So you have the intervillous blood flow, fetal placenta blood flow, the oxygen tension in the maternal artery blood and in the fetal arterial blood. You have the affinity for oxygen in the maternal blood as well as the fetus. hemoglobin carrying capacity of the fetus and the mother. And we also examine like the blood pH and PCO2, which is basically the Bohr effect. Also, we have talk factors are the placenta diffusion capacity, placenta vascular geometry, the ratio maternal and fetal blood flow in exchange areas. You could also have shunting around the exchange areas that will greatly affect oxygen transfer. And also the placenta oxygen consumption, that if the placenta requires more oxygen, that means we need more blood flow to the area. And Mira is going to be taking over for the next section. She's going to be introducing epidural anesthesia and their approaches.
Hello everyone, here is Muriel. I'll be covering the last section of this video. So some of the advantage of having an epidural include the fact that it is safe and is effective for labor analgesia. It gives the ability to the nurse anesthetic to provide a segmental block on the patient requirement. It also, with an epidural, you also have the ability to dilute your concentration of your local anesthetic without necessarily having a significant motor block. It also helps to convert labor epidural into a surgical anesthesia. Like for instance, a patient has to have an emergency C-section. If she already had an epidural, well, it would just be easier to go ahead and give a higher concentration of a local anesthetic, like a chloroquine, typically 2 to 3%, just so she can get that blocking quickly and get that C-section done. On the next slide, epidural works a little bit different comparing to spinal. It has more like of a slow onset of action, just because of the fact that once you give the local anesthetic, once it's already in the epidural space, it has to diffuse to the dura before it gets to the nerve root. And so it has a little bit of a slow process comparing, for instance, to spinal, where when you give that local anesthetic, it's going to walk directly to those nerve root and give you the blockage you need. And epidural also is highly dependent on the spread, on the volume. So the bigger the volume you give to the patient, the bigger the spread and the bigger or quickly the blockage you will need to get for that patient. When it comes to differential blockade, there's no autonomic differential blockade comparing, for instance, to like spinal. So the sensory block for epidural is about 2 to 4 dermatom higher than the motor. So if, for instance, we have a sensory block of about T4, if you want to get to a motor block, you have to get to about T6 to T8 to get that motor block. On the next slide, this pretty much lists the different equipment that you will need for your epidural. For instance, you need a blood pressure cuff, pulse oximeter, hat, a sterile and non-sterile glove, a sterile gown, and an epidural kit. When it comes to the different technique used to place an epidural, you have a midline approach or a paramedian approach. So I'm going to first explain the midline approach, which typically you want the patient in a sitting position. And so you're going to go ahead and palpate your iliac crest so that you can get your landmark, which is usually between L3, L4. Then you're going to go ahead and palpate all the spinal process and then locate your L2, L4, like I just mentioned. And then once you get the needle, when you introduce the needle in the midline, you want to direct a little bit safer that. And then as you progress, you're going to go to the different layer, like your skin, the subcutaneous tissue, you're going to go to the ligament, and then you're going to feel like a popping sensation. And at that moment, you can go ahead and connect your syringe to check for loss of resistance. But then on the next slide, when we look at the paramedian approach, it's mainly used for thoracic epidural or for larger patient or older patient with like history of arthritis. So with this one, you pretty much go laterally, and pretty much it can be lateral either on the right or on the left side, like 1 centimeter laterally. And with this one, what you do, you pretty much bypass your supraspinous and your interspinous ligament. So you go to the skin, the subq, and then go directly to the ligament, your ligamentum flavum. And at that point, you're gonna get that sensation, and then you could go ahead and connect your syringe to check for loss of resistance. So on the next picture, on the next slide is pretty much like a picture that differentiates both of them. As you can see here, the midline one, it typically goes straight, just like the name says it. It's gonna go to the different layer, like I mentioned earlier, skin, subq, all the way to the ligamentum flavum, and then get to the epidural space. But then with the paramedian, it's gonna bypass those ligaments and then get straight to the ligamentum flavum to get to the epidural space. And this last slide pretty much conclude this section on the epidural approach and the labor during pregnancy. So we would like to thank you. We would like to thank you once again for your attention. If you have any questions, don't hesitate to leave it on our YouTube page or contact us on our WhatsApp forum. Thank you again, and we'll see you next time.